Thank you, and good morning. I appreciate the opportunity to talk to you about this, and it is really an exciting time in myeloid malignancies in general. Certainly that you've been hearing yesterday and today. We know of the recent approvals in the AML world, which I think we all find very hopeful and exciting for our patients. So there are some areas of experimental need in MDS, and certainly you've heard from several of the previous speakers that we have limited actually approved therapies in this arena. And I think we are working with CCUS and ICUS and mutation panels and the drugs that we do have to refine our goals of therapy and how we're going to approach our patients based on as much up-to-date knowledge as we have. Certainly the hypomethylating agent failures continue to be a very consistent challenge in our practice. And I'll try and show you some of the recent data in the novel therapeutics that I think is both hopeful and also illustrative in terms of the patterns of experimental approaches in MDS. And something I find I very much enjoy seeing a very high volume of patients and do this regularly, that often it's an important discussion at the bedside just to let the patient know that there are opportunities, there are clinical trials, even if they ultimately don't have the capacity to enroll. It's something I think they enjoy hearing about, to know at least there's hope and options in the field. So again, there are only 3 drugs that are FDA approved in our field, and you can sort of see this timeline historically, and we'll use it a little bit going through. We also use erythropoiesis stimulating agents very regularly, though they're actually not FDA approved for this indication. And the approvals for the drugs that we do have came after a lot of basic research, and I think we're in that ramp-up phase again. It started back in the 70s with cytogenetics and a few things of that nature, and that led to the drugs that we do have, and we're ramping up again with the next-gen sequencing panels and so forth. And that's actually how some of the most recent drugs have been approved in AML, and I very much hope to see the same thing in MDS. So in terms of the goals, these are very much echoing what Rami said in terms of practical bedside management. And I really do review these with the patients and in my own head before I think about what either non-standard or standard or true clinical trial therapies I offer them. I think the obvious goals are in the blue bullet points, but I think the higher goals and why the experimental arena is really blossoming is that oral therapy, healthcare, quality of life is considered quite an important metric in today's patient arena, and drugs that we have the ability to modify the dosing so we can fine-tune and use that rheostat at the individual patient level is very appealing as well, and we're working through those challenges. So I won't belabor this intergroup trial too much. This is ACOG 2905, which you've again heard about both from Aaron and from Rami. But this is the pattern that you'll see. I'm starting with experimental options in lower risk disease. And what we tend to do as a field is combine approved agents or agents that we do know work and figure out how to make them better. And this was a study that did just this in lower risk transfusion dependent MDS patients using lenalidomide as well as an erythropoiesis stimulating agent. And you've already heard the conclusion. It was presented at ASH, and I think we'll anticipate a publication in the near term. But the duration of major erythroid response was longer in patients who received a combination of lenalidomide and erythropoietin. And so this combination can be well tolerated, and there was no risk of thromboembolism in these patients. And so this is something that can be considered in this fashion for our patients. As we move forward, though, in trying to get out of combinations of the approved agents, we have to think about some of the newer agents. And an approach in all therapies is to look at an alternative mechanism of trying to improve what we know needs to be increased in a patient. And I talk here about 2 drugs. These are fusion proteins that contain modified activin receptors. There's a type 2A or a type 2B. And these are 2 clinical trials that have been presented at ASH in the past and are coming forward into peer-reviewed publications and ongoing phase 3 trials. So this class of agents, I show you just a small schematic of it there, have a mechanism that's quite distinct from erythropoietin. And the goal is to act on late-stage erythropoiesis to increase the mature red blood cells in the circulation. Dr. Komrajki had led the US study of sotatercept, and this showed red cell transfusion independence in 43% of the patients that got it on the phase 2. Another agent called luspatercept, or ACE-536, showed very similar results in the study that was done in Europe and presented at ASH. What was unique about these patients is those who responded had a particular phenotype, and these were patients who had the ring sideroblast and an SF3B1 mutation. So starting to draw into our clinical trials the use of that next generation sequencing to predict which patients might respond better. And this has led to a phase 3, the Medalist trial, conducted in the US and Europe. It's a randomized 2-to-1 of luspatercept in patients every 3 weeks at subcutaneous dosing. This is close to accrual. I think we'll be looking forward to starting to see some of the results coming out, and the field has high optimism for drugs in this category in terms of increasing erythropoiesis for our anemic, lower-risk MDS patients. So the next thing to think about, again, drawing in some of the basic biology, is these spliceosome mutations that we keep hearing about. So we've looked at a novel mechanism in the previous study. We're now starting to drill down even more into the science, and we heard from Dr. Steemsma and others that spliceosome mutations certainly are prevalent and important in lower-risk MDS. And we see a lot of recurrent mutations in SF3B1, which I think we hear the most about because it's almost phenotype defining in refractory anemia with ring sideroblast, but certainly U2AF1, SRSF2, and ZRSR2 are all useful mutations in the spliceosome domain for us to think about with targeting in our therapeutic endeavors. So these are heterozygous mutations. They're often mutually exclusive, and of course they cause aberrant splicing. So we want to exploit this, and this is the way a lot of labs are starting to try and translate their basic science findings from the laboratory into the clinic, is exploiting these mechanisms that we're gaining increased understanding of. And there is an ongoing trial that's recruiting at the pace that a phase 1 study often does recruit, of an oral agent that is a spliceosome inhibitor called H3B8800. And this is looking in different populations. There's actually an AML portion of the cohort, but for our purposes, MDS, CMML, and looking at patients who have specific spliceosome mutations and might benefit from this type of agent in terms of increasing their erythropoiesis. It's still very early for this study. I like the concept of a targeted agent. We all do, as we're sending these mutations and trying to explain these to our patients. And I think this will be something to look for in years to come as we hope to have more novel agents for our patients. So let's move a little bit away from the lower risk arena and into options for those who are HMA failure. I still feel this is almost the holy grail of experimental therapies in some ways in the myelodysplastic world, because so many patients have seen these agents for one reason or another. As you heard from Rami, we're treating the patient at the bedside and trying to give them an option that may have meaning to the biology of their disease and their clinical outcomes. But the progression at any time after an HMA therapy is really quite disheartening. And this can be defined in many different ways. I show you here some definitions that I find useful when I think how to stratify these patients. Certainly if they have increasing blasts in the peripheral blood or bone marrow, this is very obvious. But if they've received appropriate standard dosing for 4 to 6 cycles and they don't have hematologic improvement or even a PR or CR, then maybe we need to be thinking about next therapies for them. And even if they did initially respond and have a durable time on drug where they were transfusion independent and so forth, they certainly can have progression thereafter. And then there are the patients that are simply unable to tolerate them due to unmanageable toxicities, and we have to think about alternative therapeutics for them as well. So I just show these curves to show you why I think this remains an important arena as we look through new drugs. Even if someone had lower risk disease, the median overall survival after someone has progressed through an HMA is not a curve I would like to be on, and the same is certainly true in higher risk disease on your right, where the median overall survival is quite low. So again, similar pattern as to we saw in the lower risk disease. The first way that the cooperative groups and all of us like to think about how to help these patients is combining more standard therapies. Aaron mentioned this a moment ago, but this was the S11-17 intergroup study that came out in JCO just this past summer. And what this looked at were 3 cohorts of untreated, higher risk MDS or CMML, and they either received hypomethylating agent, azacitidine alone, again at what is considered standard dosing for higher risk patients, 75 milligrams per meter squared on days 1 through 7. compared to a cohort of, again, a combination therapy of aza plus lenalidomide. You see the dosing there. And then a third experimental arm, which is aza plus vorinostat. It's been quite common to combine hypomethylating agents with compounds such as vorinostat, HDAC inhibitors to see if we can increase the response rates. The median age in this trial was pretty much our standard patient, 70 years, and sort of a 2-to-1 males to female ratio in the population. So I think very representative of the real world look. What they saw was, as we see here in the response table, the overall response rates were not significantly different between the arms. There were a few things that got teased out in this particular group, that the hematologic improvement was a bit lower than had been seen in some. The median overall response in terms of duration of months was listed there in the third line. And then the overall survival, which we all tend to focus on, was not statistically significant between the three arms. The overall response rate was higher in those patients who had DNMT3A mutations and lower for those who had SRSF2 mutations. And so that sort of tells us a couple things. We have been hearing about how to incorporate these next-gen sequencing panels, and Rami had alluded to this in the clinic as well. Maybe if you do have simply just a DNMT3A mutation, you may be more likely to respond to a hypomethylating combo. And then in terms of the SRSF2 mutation, this is not unexpected based on some of the basic science, but it reminds us that all spliceosome mutations are not created equal. Certainly, the duration of response was improved if the patients had fewer mutations, which I think stands to reason in terms of what we've heard this morning about clonality. And then what was interesting is that the CMML patients, given at this meeting we're also speaking about overlap disorders a bit, the overall response rate in the aza plus lenalidomide arm was higher for the CMML patients compared to azacitidine alone. So again, something to think about for our patients. So moving again towards experimental therapies that are ongoing in clinical trials out in the world, I show you data from this past ASH of a phase 1 study of a compound that is, I think, unique and getting towards some of the goals we spoke about earlier in MDS therapies. This is an oral drug. It's an orally bioavailability compound that's analogous to decitabine. And this is important because it's combined with an oral form of cytamine deaminase. And cytamine deaminase has long been known to degrade decitabine in the gut. And so the novel compound, that again is a pill, has the ability to potentiate the effects of an oral decitabine so that the combination can be given by mouth to patients. And this new combination was presented at ASH. The phase 1 data only. The phase 2 portion of the study is continued, and I think we'll look forward to it at the coming ASH. But the primary objective of this was to look at simply safety and to ensure that the PKs, or the areas under the curve, of this oral combination were comparable to what we could expect from our IV decitabine data that we have from the past. Each patient was their own control in this study, and it was very interesting to see that in the phase 1 results, again presented by Dr. Garcia-Manero this past ASH, that by the time the study got to cohort 2, as they ramped up the various doses of the decitabine, okay, sorry, we don't have a great pointer, but as we ramped up the decitabine and the oral cytamine deaminase inhibitor, by the time we got up to cohort 4, these patients were receiving more than what would have been the area under the curve for IV decitabine alone. So this was very hopeful that this combination could be helpful to patients. And you can see there that the dose-dependent increase in the decitabine exposure really proceeded in a very linear fashion as you increase the doses of either drug. And this allowed the phase 1 portion of the drug to come to a consensus about the appropriate dose of the cytamine deaminase inhibitor as well as the oral decitabine. And the clinical responses, this was early data certainly, and I think we'll see more coming out, but it again gives the field hope that an oral combination can certainly have efficacy in terms of clinical response in this. Responses were observed in all cohorts, and this included patients who had already failed one of the IV hypomethylating agents at the time of treatment, and there were 56% of the patients in the latter two cohorts that had been previously treated. The response rates listed there, only 9% were complete responses, but probably some meaningful hematologic improvement in the remainder. And so again, an oral combination that's still in clinical trials, but more data will be forthcoming as we work through this trial. Always wanting to fit into the oncologic world, certainly immunotherapy has been quite the buzzword recently, and often when patients come to me and ask for the latest and greatest immunotherapy in MDS, we have to have a sort of complicated discussion about what exactly immunotherapy means and how transplant has long been used in MDS and is certainly also a form of immunotherapy and how all this fits in. But particularly in MDS, nivolumab as well as ipilimumab have been looked at in this arena as well. And some people in the room have participated in these studies as well as the science. But there was this study that again was presented at ASH looking at patients who had failed HMAs as well as those who had yet to receive any therapy, and the various cohorts are seen here. This was a fairly complicated study design, but it did allow a good portion of MDS patients that wanted to have the ability to be exposed to one of these immunotherapies to see drug. I think there's some caution as we interpret the results, but you can see here the different cohorts listed in terms of HMA failure who either got nivolumab alone, ipilimumab alone, or those who are treatment naive and ended up with a combination with HMAs. And again, small numbers. These are abstracts, so you have a flavor for what's ongoing in investigations. But there were no complete responses in the nivolumab alone arm, only one in ipilimumab alone. There were 6 patients in the treatment-naive combination. So it's something that I think will probably be explored a little bit further, but I think we're not seeing the type of responses that are being seen in some of the solid tumors and so forth. So rigosertib is another option and thought for patients. I'm going to show you here the phase 2 data. There's an ongoing phase 3 study that's based on this data. And again, this is novel mechanism, and that's why we're trying to find different ways other than the way that HMA therapies treat our patients. This is something that inhibits cellular signaling. It acts actually as a RAS mimetic. There's a lot of good science behind this study in terms of how the mechanism of the drug may actually impact the aberrant signaling in MDS is something that there's still some ongoing investigations, but the initial early studies had showed there was clinical activity, and because it has oral and IV potential, since both formulations are available, it's again something our patients would like to consider. This is a phase 2. I show the dosing here so that you have a sense. This was presented at the International MDS meeting, and these are the eligibility criteria for the patients that got presented there. And at the time that this abstract was presented, they showed how patients who were prior HMA failures had done. There actually weren't a lot of patients to present, and that's something you've probably noticed as a pattern when we talk about experimental therapeutics in the MDS world. But we do learn things and value these small number of patients that participate in our clinical trials. There were a range of previous therapies in terms of azacitidine, decitabine, or actually both, and how long they had received it, from 4 to 20 cycles. The hematologic response are listed out there. And I think an active area for discussion whenever we evaluate how patients really did on a clinical trial is complete response, partial response, and then this concept in MDS of marrow CR that I think none of us are entirely sure the clinical significance of, as well as stable disease, which, as Rami mentioned earlier, may have value in individual patients depending on what you're looking at in terms of durability needs and so forth. Hematologic improvement that was trilineage was also observed in a few patients, and this data has allowed this drug to go forward in a phase 3. So last, as we've started the day with talking about clonal mutations and next-gen sequencing, I'll just round out with IDH mutations. I mentioned earlier, I feel like it's been an exciting couple months in terms of approvals in AML, and we know that mutant IDH2 in particular occurs in about 5% of patients with MDS. we have a good sense of the mechanism of this because it alters DNA methylation and blocks cellular differentiation. This compound, AG221, which was just approved in relapsed and refractory AML, has the same phase 1/2 data that got it approved in that arena, did have patients who had MDS on it, as well as patients that had progressed from MDS. And so you can see there that there were 17 MDS patients treated. And in terms of response data, the overall response was a little over 50% in these 17 patients that we saw. And it's broken down there in terms of complete response, which was only 1, partial response, also only 1, and then marrow CR as well as hematologic improvement. This was a fairly heavily pretreated group of patients, and of those who had previously received HMA therapy, 7, or a little over half, did have a response with this compound. And in terms of the hematologic improvement, there was some trilineage and some bilineage. And I think what's nice about this particular combination and the draw for me personally, and I think for patients, is with some of these targeted agents, the time to response can be quite quick. And so if the toxicities are manageable and you have a little bit of time to give it, it may be worth seeing how early you can see the response for them. So lastly, just keep remembering there's plenty of hope and opportunity in this area. We're gaining a lot of new knowledge. You can sort of see as we've come through the past several decades that each time we get a new diagnostic technology, it does take some time, but the therapeutics follow, and I think that's the beauty of the field. We have a new WHO, we have lots of new Nextgen data, and I do think we're going to have a new drug in the next couple of years in MDS. It's still an area of significant medical need. You've heard from Amr and others how valuable it is for these patients to participate in their studies. We are evolving rapidly from a diagnostic perspective, and talks like David's give us the benefit of learning how we utilize these techniques at the bedside. It's always going to be slower from a therapeutic perspective, but there's a lot of new trials. I'll mention 2 in particular that I think really should be considered if a patient has the capacity. There's targeted trials in MDS. I think it would be exciting to have an approval for the new IDH2 inhibitor also in MDS, not just AML. And Dr. Solomon, who you heard from yesterday, is leading an initiative with specific P53 mutated patients who would all love to help more. In the future certainly will be the next drug approval in our arena. So thank you very much for your time.